Question 1. Radiation protection and safety. A patient is undergoing radiation therapy for prostate cancer using a linear accelerator. The treatment team ensures that all safety protocols are in place, including shielding and exposure monitoring. However, a dosimeter reading for a radiation therapist shows a significantly higher exposure than the annual limit recommended by the National Council on Radiation Protection and Measurements (SRP). Should be the next course of action in accordance with radiation protection guidelines. A. Immediately suspend all radiation treatments until the cause of the high exposure is identified. B. Conduct an investigation into the exposure, assess workplace practices, and implement corrective measures. C. Assume the dosimeter is malfunctioning and continue normal operations. D. Increase shielding for patients while maintaining current exposure levels for staff. Answer. B. Conduct an investigation into the exposure, assess workplace practices, and implement corrective measures. Explanation. According to NRP Report Note 116 and ALARA, as low as reasonably achievable, principles exceeding the occupational dose limit, 50 MSV per year for radiation workers, requires an immediate investigation to determine the cause. The Radiation Safety Officer or SO must review dosimetry, workplace shielding, and possible procedural errors. Simply assuming a dosimeter malfunction, option C, is unsafe without verification, while stopping all treatments, option A, is unnecessary unless an immediate hazard is identified. Increasing shielding for patients, option D, does not address the staff's exposure problem. Question 2. Clinical concepts in oncologic pathology, scenario-based. Mrs. Rodriguez, a 56-year-old patient with stage Roman breast cancer, is undergoing radiation therapy following a lumpectomy. She reports increasing skin erythema, dryness, and mild pain in the treated area. As a radiation therapist, what should you advise her to minimize further skin reactions and ensure treatment completion? A. Apply petroleum-based ointments before each radiation session. B. Continue treatment as planned and use mild, fragrance-free moisturizers after sessions. C. Reduce radiation dose immediately to prevent further skin irritation. D. Use an alcohol-based antiseptic before and after each treatment to keep the skin dry. Answer. B. Continue treatment as planned and use mild, fragrance-free moisturizers after sessions. Explanation. Radiation-induced dermatitis is a common side effect of external beam radiation therapy, particularly for breast cancer. Best practices, as outlined by the National Comprehensive Cancer Network (SEN), recommend the use of non-irritating, fragrance-free moisturizers after treatments to soothe the skin. Petroleum-based ointments should be avoided before radiation, as they can create a bolus effect, increasing surface dose absorption. Reducing radiation dose, option C, is not a recommended approach unless severe toxicity is observed. Alcohol-based antiseptics, option D, can further dry and irritate the skin, worsening the reaction. Question 3. Treatment planning and dosimetry. When calculating monitor units move for a treatment plan using a linear accelerator, which of the following factors must be taken into account to ensure accurate dose delivery? A. The inverse square law, tissue heterogeneity, beam attenuation, and prescribed dose. B. Only the prescribed dose, as it is the most important factor. C. The patient's body mass index, BMI, and age to determine optimal beam energy. D. The monitor unit settings should always remain constant regardless of patient anatomy. Answer A. The inverse square law, tissue heterogeneity, beam attenuation, and prescribed dose. Explanation. Accurate mu calculations are essential for delivering the correct radiation dose. According to OPM, American Association of Physicists in Medicine, guidelines, factors influencing mu calculations include inverse square law, accounts for changes in doses, distance from the source varies, tissue heterogeneity, different tissues, bone, soft tissue, absorb radiation differently, beam attenuation, energy loss as the beam passes through matter, prescribed dose, must be accurately delivered to the target volume while sparing surrounding tissue. Options B, C, and D are incorrect because relying solely on the prescribed dose without considering other factors, option B, leads to inaccurate treatment. BMI and age, option C, are not primary determinants in mu calculations, and mu settings must be adjusted per patient anatomy, option D. Question 4. Patient care and communication. During an initial consultation for radiation therapy, a patient expresses strong concerns about the potential side effects and effectiveness of the treatment. The patient is hesitant and mentions that they have read conflicting information online. As A radiation therapist, how should you handle this situation to ensure the patient receives accurate information and maintains trust in the treatment process? A. Provide the patient with simplified information and discourage them from researching further to avoid confusion. B. Listen to the patient's concerns, provide evidence-based education, and encourage an open dialogue with the radiation oncologist. C. Reassure the patient that all radiation therapy treatments are safe and effective without addressing specific concerns. D. Refer the patient to online forums and support groups for additional information. Answer. B. Listen to the patient's concerns, provide evidence-based education, and encourage an open dialogue with the radiation oncologist. Explanation. Effective patient communication is a critical aspect of radiation therapy. According to the American Society for Radiation Oncology (ASTRO) guidelines, patient education should be based on evidence-based resources and should address concerns through open and transparent communication. Discourage the patient from further research. Option A is inappropriate, as patients have right to be informed. Providing blanket reassurance. Option C, without addressing concerns, lacks depth and fails to build trust, while support groups. Option D can be beneficial. They should not replace professional medical guidance. Question 5. Radiation physics and principles. In a radiation therapy treatment using a 6 MV photon beam, the prescribed dose to a deep-seated tumor is 2 Gy per fraction. Given that the patient has a high-density prosthetic implant near the treatment area, what considerations must be made to ensure accurate dose delivery? A. No adjustments are needed since photon beams penetrate all materials uniformly. Increase the dose by 20% to compensate for the increased attenuation from the prosthetic implant. C. Evaluate dose distribution using CT simulation and adjust planning based on tissue heterogeneity corrections. D. Use a lower energy beam G 4MV to minimize the effect of the prosthetic material on beam attenuation. Answer. C. Evaluate dose distribution using CT simulation and adjust planning based on tissue heterogeneity corrections. Explanation. Metallic prosthetics can attenuate or scatter radiation, affecting dose distribution. According to OPA TG63 recommendations, advanced treatment planning should involve CT-based dose calculations to assess attenuation effects, heterogeneity corrections to adjust for the density difference between metal and soft tissue, alternative beam angles, or IMET planning to mitigate dose perturbations. Increasing the dose arbitrarily. Option B is unsafe without dosimetric evaluation. Lowering beam energy. Option D is not always beneficial, as lower MV beams may result in higher attenuation through dense materials. Question 6. Radiation protection and safety. A radiation therapy department is reviewing its annual radiation safety audit and discovers that one of its linear accelerators has had multiple instances of unshielded scatter radiation exposure outside the designated treatment room. What is the most appropriate action to take to comply with regulatory safety standards? A. Immediately shut down the machine and suspend all patient treatments until a full investigation is completed. B. Review shielding calculations, conduct new area radiation surveys, and implement corrective actions based on findings. C. Ignore the readings unless a staff member reports radiation-related symptoms. D. Only inform the radiation safety officer and continue regular operations until further notice. Answer. B. Review shielding calculations, conduct new area radiation surveys, and implement corrective actions based on findings. Explanation. According to SRP Report No. 151, radiation safety audits must include shielding integrity evaluations for scatter radiation leaks, dosimetry monitoring for occupational exposure compliance, corrective actions such as structural modifications or machine recalibration. Down the machine entirely. Option A may not be necessary unless severe exposure violations are found. Ignoring the issue. Option C violates federal radiation protection standards 10 CFR 20, and option D fails to ensure prompt action to protect both staff and patients. Question 7. Treatment planning and dosimetry scenario-based. Mr. Patel, a 62-year-old patient with an air cell carcinoma of the larynx, is undergoing intensity modulated radiation therapy to preserve voice function while maximizing tumor control. His treatment involves a prescribed total dose of 70 Gy in 35 fractions. However, during verification imaging, the radiation therapist notices daily shift, patient positioning exceeding 5 mm due to poor immobilization. What should be done to ensure precise dose delivery? A. Continue with treatment as planned, as minor shifts are expected in daily setup. B. Reevaluate the immobilization device, adjust positioning protocols, and consider adaptive planning. C. Increase the treatment dose by 10% to account for daily positioning errors. D. Stop all radiation treatments indefinitely until a new treatment plan is created. Answer: B. Reevaluate the immobilization device, adjust positioning protocols, and consider adaptive planning. Explanation: IMIT requires submillimeter accuracy to prevent overdose to critical structures, e.g. spinal cord, salivary glands. Best practices include using stricter immobilization techniques, e.g. thermoplastic masks, daily image guidance, IGIT, to verify alignment before treatment, adaptive planning if deviations are frequent. Increasing dose arbitrarily, option C, risks unnecessary toxicity. Completely halting treatment, option D, is unnecessary unless major dosimetric deviations are identified. Question 8. Quality assurance and equipment maintenance. A linear accelerator is undergoing its monthly quality assurance (CAR) check, and it is discovered that the output varies by more than 3% from the baseline calibration. According to Opatija 142, what should be the next step? A. Continue using the machine as long as the deviation remains below 5%. B. Recalibrate the machine immediately and verify output before treating patients. C. Ignore the deviation as minor fluctuations are expected over time. D. Increase the number of monitor units (mu) per fraction to compensate for the decreased beam output. Answer: B. Recalibrate the machine immediately and verify output before treating patients. Explanation: Opatija 142 outlines tolerance limits for radiation therapy equipment. Daily CAR, 3% tolerance for output consistency. Monthly CAR, any deviation above 2% requires investigation and possible recalibration. Annual CAR, comprehensive testing of all mechanical and dosimetric parameters. Increasing monitor units, option D, is unsafe without dosimetric verification, and ignoring deviations, option C, can lead to inaccurate dose delivery. Question 9. Cancer biology and side effect management. Which of the following best describes the relationship between radiation sensitivity and the cell cycle in determining tumor response to radiation therapy? A. Cells in the M mitotic and Gg gap2 phases are the most radiosensitive. B. Radiation equally affects all cells regardless of their cell cycle phase. C. Cells in the S synthesis phase are the most radiosensitive. D. The cell cycle does not influence radiation response. Only tissue oxygenation matters. Answer 8. Cells in the M mitotic and Gg gap2 phases are the most radiosensitive. Explanation: radiobiology research, including the 4 Rs of radiobiology, repair, reoxygenation, redistribution, repopulation, shows that M and G phases have the highest radiation sensitivity due to lack of DNA repair mechanisms. S phase cells are radioresistant due to active DNA replication. Tumor hypoxia reduces radiosensitivity but does not override cell cycle effects, option D. Thus, fractionation schedules often target rapidly dividing cells to optimize therapeutic gain. Question 10. Image-guided radiation therapy. IGIT, a patient undergoing stereotactic body radiation therapy (SRT) for a lung tumor is being treated with four-dimensional CT, forward CT, planning to account for respiratory motion. However, during daily EET imaging, the therapist observes that the tumor moves significantly beyond the planned internal target volume (TV). What is the most appropriate course of action? A. Continue treatment as planned. CIS-SRT is designed to deliver high-dose fractions. B. Use respiratory gating or fiducial markers to improve tumor localization. C. Increase the planned treatment margins to encompass the full range of tumor motion. D. Reduce the dose per fraction to minimize potential toxicity. Answer: B. Use respiratory gating or fiducial markers to improve tumor localization. Explanation: in LISRT, tumor motion due to respiration can lead to geographic miss or overdosing normal tissue. Best practices include respiratory gating, synchronizing beam delivery with the patient's breathing cycle, fiducial markers, placing radiopaque markers near the tumor for precise localization, motion management strategies, planning techniques based on real-time tumor tracking. Increasing treatment margins, option C, may unnecessarily irradiate healthy lung tissue, leading to high toxicity. Question 11. Radiation safety and shielding. A new proton therapy center is being constructed, and a medical physicist is responsible for determining the necessary barrier shielding. Compared to traditional photon therapy, what unique shielding considerations must be addressed for proton therapy facilities? A. Proton beams require thinner lead shielding than photons due to their lower energy. B. Proton therapy rooms require shielding for neutron production and secondary radiation. C. Standard photon therapy shielding is sufficient as proton beams do not scatter. D. Increasing the energy of the proton beam reduces shielding requirements. Answer: B. Proton therapy rooms require shielding for neutron production and secondary radiation. Explanation: unlike photon therapy, proton beams create neutron radiation when they interact with beamline components and patient tissues. Shielding must account for high-energy neutron production requiring additional concrete or borated polyethylene, secondary radiation scatter, which differs from X-ray scatter patterns, stray radiation out. The treatment vault requiring extensive shielding analysis. Standard photon shielding, option C, is inadequate in increasing beam energy. Option D can increase neutron contamination rather than reduce it. Question 12. Brachytherapy. High dose rate HDR considerations. Patient undergoing HDR brachytherapy for cervical cancer expresses concern about radiation exposure to her family members. As the radiation therapist, how should you address this concern? A. Reassure her that HDR brachytherapy does not require radiation precautions after treatment. B. Advise her to maintain at least 6-foot distance from family members for 1 week. C. Recommend wearing lead apron at home to reduce radiation exposure. D. Advise her to stay in an isolated hospital room for 48 hours after treatment. Answer A. Reassure her that HDR brachytherapy does not require radiation precautions after treatment. Explanation: HDR brachytherapy delivers radiation in a controlled environment using a remote afterloader. Unlike low-dose rate LDR brachytherapy, where radioactive sources remain in the body for an extended period, HDR treatments do not leave residual radiation in the patient. Therefore, no isolation or precautions are necessary after treatment. Question 13. Tumor response and hypoxia. Tumor hypoxia can significantly reduce the effectiveness of radiation therapy. Which of the following strategies can improve radiation response in hypoxic tumors? A. Hyperfractionation to increase tumor reoxygenation between doses. B. Using lower energy photon beams to reduce tissue penetration. C. Delivering all radiation in a single high-dose fraction to compensate for hypoxia. D. Avoiding chemotherapy to prevent additional stress on hypoxic cells. Answer A. Hyperfractionation to increase tumor reoxygenation between doses. Explanation: hypoxic tumor cells are radioresistant due to low oxygen availability, which reduces DNA damage from radiation. Effective strategies include hyperfractionation, delivering multiple small doses to allow tumor reoxygenation between treatments, hypoxic radiosensitizers, drugs that increase oxygen delivery to the tumor, radiation, e.g., protons, carbon, ions, to enhance biological effectiveness. Question 14. Intensity modulated radiation therapy IMET plan evaluation. When reviewing an IMET treatment plan for a prostate cancer patient, the dose volume histogram DEH shows that the rectum receives a higher than acceptable dose. What is the most appropriate modification? A. Increase the monitor unit's mu to compensate for dose loss. B. Use volumetric modulated arc therapy VMAP to improve dose conformity. C. Reduce the prescribed dose to minimize rectal toxicity. D. Proceed with treatment as planned, as the prostate is the primary target. Answer B. Use volumetric modulated arc therapy VMAP to improve dose conformity. Explanation: VMAP delivers radiation in a continuous arc, allowing for better dose conformity and organ sparing. Other methods to reduce rectal dose include using hydrogel spacers to physically separate the rectum from the prostate, increasing treatment angles to optimize beam distribution, adaptive planning to modify doses based on daily positioning. Question 15. Pediatric radiation therapy considerations. A 6-year-old child with medulloblastoma is undergoing craniospinal irradiation (CSI). What special considerations must be taken into account? A. Use anesthesia or sedation to ensure immobilization. B. Reduce radiation dose significantly to minimize late effects. C. Avoid proton therapy as it has higher toxicity in pediatric cases. D. Deliver all fractions in a single session to reduce hospital visits. Answer A. Use anesthesia or sedation to ensure immobilization. Explanation. Pediatric patients may struggle with immobilization during long treatment sessions. Proper techniques include sedation or anesthesia for younger children, custom immobilization masks for head positioning, proton therapy to reduce long-term radiation side effects in developing tissues. Question 16. Radiation-induced side effects. A breast cancer patient undergoing whole breast irradiation reports erythema, dryness, and peeling skin in the treated area. What is the most appropriate intervention? A. Recommend fragrance-free moisturizers and avoid excessive sun exposure. B. Reduce the total radiation dose to prevent further skin damage. C. Apply topical steroids without physician consultation. D. Stop radiation therapy until the skin fully heals. Answer A. Recommend fragrance-free moisturizers and avoid excessive sun exposure. Explanation. Radiation dermatitis is a common side effect. Standard management includes moisturizers and aloe vera-based lotions to soothe irritation, avoiding harsh soaps, perfumes, and tight clothing, using topical steroids only if prescribed by a physician. Question 17. Whole brain radiation Airbury effects. A patient receiving whole brain radiation therapy or brain metastasis is at increased risk for which long-term side effect? A. Neurocognitive decline, including memory loss. B. Severe alopecia that never resolves. C. Permanent blindness due to optic nerve toxicity. D. Severe immune system suppression. Answer A. Neurocognitive decline, including memory loss. Explanation. Airbury associated with cognitive impairment, particularly in hippocampal-dependent memory function. Strategies to minimize this risk include hippocampal sparing IMIT techniques, using memantine, an NADA receptor antagonist, stereotactic radiosurgery (SRS) as an alternative when possible. Question 18. Stereotactic radiosurgery (SRS) planning. A 52-year-old patient with a 3 mm brain metastases is scheduled for stereotactic radiosurgery (SRS) using a gamma knife system. The radiation oncologist prescribes a single fraction of 20 Gi. However, the physicist notes that the dose gradient to surrounding normal brain tissue is steep, which is the primary advantage of using a steep dose gradient. SRS. A. It ensures a uniform dose across the entire brain. B. It allows for high-dose delivery while minimizing exposure to adjacent tissue. C. It reduces the risk of tumor hypoxia by increasing dose spillover. D. It eliminates the need for image guidance before treatment. Answer B. It allows for high-dose delivery while minimizing exposure to adjacent tissue. Explanation. SRS is designed to maximize dose precision while minimizing collateral damage to normal brain tissue. A steep dose gradient ensures localized tumor control with high-dose irradiation, reduced toxicity to surrounding critical structures, e.g., optic nerves, brainstem, minimal impact on cognitive function, especially in deep brain lesions. Question 19. Total body irradiation (TBI) challenges. A 30-year-old patient undergoing allogeneic bone marrow transplantation is scheduled for total body irradiation (TBI) as part of their conditioning regimen. What is a major challenge in delivering TBI safely and effectively? A. Ensuring homogeneous dose distribution across the entire body. B. Using the lowest energy photon beams to enhance penetration. C. Avoiding lung shielding to prevent dose heterogeneity. D. Delivering the dose in a single large fraction for efficiency. Answer A. Ensuring homogeneous dose distribution across the entire body. Explanation. TBI requires uniform dose distribution to effectively eliminate malignant cells while sparing critical organs, lungs, kidneys, liver, etc. Common challenges include dose variation due to body thickness differences, e.g. chest versus extremities, lung shielding to reduce radiation pneumonitis risk, fractionated EBI regimens to tolerability. Question 20. Adaptive radiation therapy. A patient undergoing intensity-modulated radiation therapy IMIT for head and neck cancer exhibits significant tumor shrinkage after 3 weeks of treatment. What is the most appropriate action? They continue treatment as planned since the initial dose calculation remains valid. B. Perform a repeat CT simulation and adjust the treatment plan. C. Increase the total dose to compensate for tumor shrinkage. D. Shift to a palliative regimen due to tumor response variability. Answer B. Perform a repeat CT simulation and adjust the treatment plan. Explanation. Tumor shrinkage and anatomical changes during treatment can affect dose distribution and organ at risk or exposure target volume accuracy, risk of normal tissue overdose. Adaptive radiation therapy, ART, allows for replanning based on real-time changes, improving treatment accuracy and reducing side effects. Question 21. Pediatric radiation therapy and growth effects. A 5-year-old child undergoing cranial irradiation for medulloblastoma is at risk for which long-term complication? A. Endocrine dysfunction and growth delay. B. Increased risk of acute radiation syndrome. C. Complete radiation resistance due to tissue plasticity. D. Irreversible cognitive decline immediately after treatment. Answer A. Endocrine dysfunction and growth delay. Explanation. Pediatric patients are highly sensitive to radiation, especially pituitary and hypothalamic damage leading to growth hormone deficiency, skeletal growth abnormalities, particularly with spinal irradiation, neurocognitive effects, depending on the treatment field and dose. Question 22. Proton therapy versus photon therapy in pediatric patients. Why is proton therapy preferred over conventional photon therapy in pediatric patients? A. Proton beams deliver dose more selectively, reducing radiation to healthy tissue. B. Proton therapy eliminates the need for anesthesia in younger children. C. Proton therapy reduces the required total treatment dose. D. Proton therapy is always less expensive than photon therapy. Answer A. Proton beams deliver dose more selectively, reducing radiation to healthy tissue. Explanation. Proton therapy's Bragg peak effect allows for more precise dose delivery, lower risk of secondary malignancies, reduced long-term side effects, especially in developing organs. Question 23. Radiation-induced pulmonary toxicity. A patient undergoing chest radiation therapy for non-small cell lung cancer (SSLC) develops a persistent dry cough and dyspnea 6 weeks post-treatment. What is the most likely diagnosis? A. Radiation pneumonitis. B. Acute pulmonary embolism. C. Chronic obstructive pulmonary disease, COPD exacerbation. D. Cardiac arrhythmia from radiation exposure. Answer A. Radiation pneumonitis. Explanation. Radiation pneumonitis is a delayed inflammatory reaction occurring for 1–2 weeks post-radiation and is characterized by cough, dyspnea, low-grade fever, interstitial lung inflammation on imaging, treatment with corticosteroids if severe. Question 24. Cardiac toxicity in breast cancer radiation therapy. A 57-year-old woman undergoing left-sided whole breast irradiation is at increased risk for which long-term complication? A. Radiation-induced heart disease, RI. B. Pulmonary fibrosis. C. Chronic kidney disease. D. Spinal cord myelopathy. Answer A. Radiation-induced heart disease, RI. Explanation. Left-sided breast radiation can expose the left ventricle and coronary arteries, leading to coronary artery disease (CAD), pericarditis and fibrosis. Mitigation strategies: deep inspiration, breath hold, DIB, and proton therapy. Question 25. Image-guided brachytherapy (IGT) in cervical cancer. What is the primary advantage of image-guided brachytherapy (IGT) over conventional brachytherapy in cervical cancer? A. Improved tumor targeting and reduced normal tissue toxicity. B. Eliminates the need for external beam radiation therapy. C. Requires no CT or MRI imaging during treatment planning. D. Uses lower radiation doses than conventional brachytherapy. Answer A. Improved tumor targeting and reduced normal tissue toxicity. Explanation. IGT uses MRI for real-time treatment planning, allowing for better dose distribution to the tumor, lower exposure to bladder, rectum, and bowel, personalized treatment adjustments based on tumor response. Question 26. Or constraints in head and neck radiation therapy. During IMT planning for oropharyngeal cancer, the dose to the parotid glands must be minimized to reduce the risk of A. Xerostomia, dry mouth. B. Laryngeal necrosis. C. Optic nerve damage. D. Spinal cord injury. Answer A. Xerostomia, dry mouth. Explanation. The parotid glands produce saliva, and high radiation doses can cause permanent dry mouth, impacting swallowing and speech. Dental health, quality of life, dose constraints. Aim for 26 GI to at least one parotid gland to preserve function. Question 27. Dose constraints for spinal cord protection. A patient is receiving intensity-modulated radiation therapy (IMT) for thoracic esophageal cancer. The radiation oncologist prescribes 60 GI in 30 fractions to the gross tumor volume (GTV). What is the recommended maximum dose to the spinal cord to minimize the risk of radiation-induced myelopathy? A. 30 Gy in 30 fractions. B. 45 Gy in 30 fractions. C. 60 Gy in 30 fractions. D. 55 Gy in 30 fractions. Answer: B. 45 Gy in 30 fractions. Explanation: radiation-induced myelopathy is a severe late toxicity that can result in permanent neurological deficits. The tolerance dose TD5 for the spinal cord is 45 Gy in conventional fractionation, 1.82 Gy per fraction. Doses above 50 Gy significantly increase the risk of myelopathy. Advanced techniques e.g. emit proton therapy help spinal cord dose while maintaining tumor coverage. Question 28. Radiation necrosis in brain tumor treatment. A 65-year-old patient with a high-grade glioblastoma multiforme (GBM) received 60 Gy in 30 fractions with concurrent temozolomide. 6 months post-treatment, the patient presents with progressive neurological deficits and worsening MRI enhancement at the original tumor site. Which imaging technique is most useful to differentiate radiation necrosis for tumor recurrence? A. Contrast-enhanced CT. B. Diffusion-weighted MRI. C. PET scan with amino acid tracers. E.g. PET or MET-PET. D. Non-contrast MRI. Answer: C. PET scan with amino acid tracers. E.g. PET or MET-PET. Explanation: radiation necrosis can mimic tumor recurrence and MRI, making diagnosis challenging. Advanced imaging techniques include amino acid PET, PET, MET-PET differentiates tumor growth, high metabolic activity from necrosis, low metabolic activity. Mr. Spectroscopy misses. High choline creatine ratio suggests tumor recurrence. MRI. Tumor recurrence often shows higher blood flow than radiation necrosis. Question 29. Total skin electron therapy set for mycosis fungoids. A 45-year-old patient with stage-year mycosis fungoides, cutaneous T-cell lymphoma, is treated with total skin electron therapy set. Why is electron therapy preferred over photon-based treatment for this condition? A. Electrons provide superficial tissue penetration with minimal deep tissue dose. B. Electrons can penetrate deeply into muscle and bone. C. Electrons require fewer treatment fractions compared to photons. D. Electron therapy does not cause any acute skin toxicity. Answer A. Electrons provide superficial tissue penetration with minimal deep tissue dose. Explanation: mycosis fungoides is a skin-based lymphoma, therefore treatment requires superficial dose delivery while sparing deeper tissues. Electron therapy has a limited penetration depth, 1-2 cm, making it ideal for skin diseases, reduces dose to internal organs, minimizing systemic toxicity, can be delivered using SET technique, widespread cutaneous disease. Question 30. Brachytherapy in prostate cancer. A 70-year-old patient with low-risk prostate cancer, Gleason 6 is CT-GML for low dose rate, LDR, brachytherapy. Which radioactive isotope is most commonly used for permanent LDR prostate brachytherapy? Iodine 125, I-125. B. Iridium 192, O192. C. Cesium 137, Cs 137. D. Radium 223, Ro 223. Answer: iodine 125, I-125. Explanation: LDR prostate brachytherapy uses permanently implanted radioactive seeds to deliver localized radiation over several months. The most common isotopes are I-125, half-life 60 days. Deliver slow, continuous dose. Palladium 103, P2 half-life 17 days. Used for more aggressive tumors. High dose rate. Iridium 192 and Cesium 137 are used for HDR, high dose rate, brachytherapy, while Radium 223 is used for bone metastasis, not prostate implants.